This is your brain on drugs. This is your punk rock psychiatrist. And that was Walk by Snuff. I chose that song, one, because I didn't have a chance to use Walk in the physical fitness section because I didn't have enough episodes on that. And I was saving it for that. And we're still talking about, losing weight and being in shape. And so I thought Walk would be good. And I have not used a Snuff song. So I also thought that would be good. So today, actually, I think a lot of you are going to be excited to finally hear about the meds. You've probably been thinking, like, why has this guy been talking about weight loss for 6 months? And he's a physician and he hasn't talked about the medications yet. And, it's because I was trying to go in order to talk about what we would use first. And I like to go in detail here so that you have all the details, like I want you to walk away from this podcast thinking, I don't really need to read a book. I don't really need to go to a class. I don't really need to do anything. This guy has told me every single thing I would need to know in order to safely use and prescribe these medications. And in fact, he's given me too much information. So that's kind of the way we like to do it here at This Is Your Brain on Drugs. And so we have finally got to the juicy bit. We are going to talk about weight loss medications. And there are, surprisingly to many of you, about 20. So you're probably thinking, I maybe know 3 or 4. Well, there are a ton of them. And I will breeze through the ones that you're going to be less interested in, but I'm going to mention them anyway because no one does. No one talks about them. They're out there. No one talks about them. They exist. I don't know if anyone's getting prescribed them, but I think it's important to kind of document all that. But today we're going to start chronologically. The first stimulant to ever come out was Phentermine for weight loss that I'm aware of. So we're going to start with the stimulants. These are medications that work as norepinephrine in norepinephrine ways. So they increase norepinephrine. Typically that may be through norepinephrine reuptake inhibition. It could be through norepinephrine releasing. Some of these are norepinephrine releasing agents. So the difference there would be if you're a releasing agent, you are forcing norepinephrine out of the nerve terminal to interact with the next nerve cell. And if you're a norepinephrine reuptake inhibitor, you're blocking the reuptake pump that is sucking the norepinephrine out. And some of these do both. And this is the main way on how appetite is suppressed. And so we're going to talk about the medications that use this method first. And today we're going to cover 2 medications that you're going to be really interested in, Phentermine and Vyvanse, lisdexamfetamine. And we are going to talk about a bunch of other ones that are less used. That doesn't mean they couldn't be. And then next time we will talk about the 2 others that you probably heard of, Qsymia and Contrave. And so I'm going to break this first part up into 2 episodes. We'll talk about the non-GLP-1 medications in the first 2 episodes. And then I'm going to have a lot of episodes on the GLP-1 medications, which I'm sure is what everyone already knows about because it's been taking me so long to get to this. But hopefully there's a lot to learn for you on this podcast. So let's start ourselves out with Phentermine, brand name Adipex. A lot of these old brand name meds, I like to mention the brand name. I think if I'm issuing CMEs, I'm not even allowed to mention the brand names. I think it's important to know a lot of these brands are not even produced anymore because they've been generic so long. I believe this is one of them. I don't think Adipex is available, but I think it's important to know. If you ever heard the term, I think it'd be nice for you to know that we are actually talking about Phentermine here. If you're reading something, you're looking at an old ad, oh, Adipex, what is that? It's Phentermine. All right, so this drug has been out. It's pretty much longer than the FDA has been approving drugs. I'm pretty sure the FDA started doing the formal approval process in the 1970s. It was not handled as strictly prior to that. This med is prior to that, 1959. It's one of the oldest meds we've talked about so far. Not the oldest, but 1959, pretty old. A lot of these medications that are stimulants are controlled substances, We haven't talked about controlled substances in detail. Schedule 1, can't prescribe. Schedule 2, can't do refills, can't give more than 3 months supply. That'd be like most of your opiates, most of your ADHD meds, Schedule 2. There's Schedule 3. Ketamine is a Schedule 3. There's more opiates in Schedule 3. Schedule 4 is a lot of our benzos, meds like that. And then Schedule 5, Lyrica is in Schedule 5. There's not a lot in Schedule 5. And like basically the higher the number, the less risk they're saying. So phentermine is Schedule 4, which means you do have to have like a license to prescribe scheduled substances. You have to have a DEA number. Do I agree with phentermine being Schedule 4? I do not. I don't. I think this is old, outdated. I don't think it's not like it's that hard to prescribe a Schedule 4, but I think some people might think, oh, a Schedule 4, maybe I should be more careful with that. Yeah, with phentermine, not so much. Let's learn about it. How does this thing work? All right. So as I said, we're talking about norepinephrine drugs. So this is actually a norepinephrine releasing agent. Remember I said there's norepinephrine releasing agents and reuptake inhibitors. Releasing agent is a bit more powerful. So if you were thinking, hey, this is kind of like Strattera, which I actually talked about in the previous episode. This is like Strattera, right? It's like a norepinephrine reuptake inhibitor. No, it's actually a norepinephrine releasing agent. So most of our standard psychiatric meds are reuptake inhibitors. The Adderall has some dopamine releasing agent effects in addition to being a dopamine reuptake inhibitor. It's one of the only ones that's a releasing agent. This is another one. I don't know if you'd call this a psychiatric medication or not. I certainly think we could categorize it there. It can definitely be used in psychiatry. Another medication I think so Adderall has some dopamine releasing agent properties. Phentermine's got some norepinephrine releasing properties. So you may be wondering, what's a serotonin releasing agent? Well, MDMA, ecstasy is a serotonin releasing. That's why it's so powerful. If you just had a really powerful SSRI, you're just blocking serotonin from being destroyed. But when you release serotonin from the nerve terminal, for those of you that have ever used ecstasy, what happens is you drain all of your serotonin from your brain. Not all of it, but most of it. And you don't have much serotonin after that. It just all gets blasted out into the synaptic cleft, and it takes you a few days to build your serotonin back. And that's why if you use agents that are serotonin releasing agents, and ecstasy is about the most powerful one that I'm aware of. There are others that have that quality, but not quite like ecstasy. You feel like crap for days. To me, that should be enough of an incentive not to use it. A few hours of like ecstasy for like 3 days of like absolute misery. I mean, I'm talking like no motivation to do anything. Don't want to eat, can't sleep, don't want to sleep, don't want to talk to people, don't want to be around people, don't want to be awake, don't want to be asleep. Just absolute hell. It's not really worth it, is it? So the phentermine, back to phentermine, is a norepinephrine releasing agent. It does release dopamine and serotonin to a much lesser extent, and taken in normal doses. This is not really something that we should be overly concerned about. But yeah, it can do some serotonin, so that's why you might see it on some like lists of something to be concerned about for serotonin syndrome. But it's primarily a norepinephrine releasing agent. The effect this has is as an appetite suppression, but without euphoria. Okay, so this medication is not known to be addictive. For some reason, it gets this Schedule 4 substance moniker attached to it. But there isn't euphoria. There isn't addictive qualities. This is actually a pretty safe medication. And we're going to talk about a little more. Like, there's a lot of reasons why people got to be afraid of phentermine. One is the Schedule 4. People see that Schedule 4 and they think, benzos are Schedule 4. I don't want to just give someone a Schedule 4 drug to lose weight. I feel like that's like irresponsible. and so they might be afraid of that. Um, and we'll talk as we go down through it. We'll talk about some of the other reasons why phentermine has gotten a bad rap. But it has a couple of mechanisms of action. So not just the norepinephrine releasing agent effect, it also activates, and let's see if I can pronounce this correctly the first time. I doubt it. So it's POMC. That's what you would commonly know it as. Pro-opiomelanocortin. Oh man, I did it. Pro-opiomelanocortin, POMC. So activates pro-opiomelanocortin neurons in the hypothalamus. This has an appetite suppression effect. Um, I don't know if you all have heard of this POMC, but this is how naltrexone works. This is how bupropion works. This is how there's other medications that actually work on this POMC, and so that's actually a really important effect. So it's not just a norepinephrine releasing agent, which does suppress appetite. It also activates pro-opiomelanocortin neurons in the hypothalamus, which is where our hunger is. That also suppresses appetite. So we got a little double shot there. All right. So this is FDA approved for short-term weight loss for those greater than or equal to 17. When we finish all these, I'm going to tell you like all the age ranges. Like there's some funny age ranges. Like some of them you have to be 18. This one you get to be 17. It's like 1 year less. I don't know how that works. I don't know why this is approved for 17. And why do 17-year-olds get to use this, but some other med we have to wait till 18? Why a year early here? I have no idea, but it's FDA approved for 17 and up. And this short-term weight loss thing, we're going to talk about this in a second. And the average amount of weight loss we're seeing here is 5 to 7%. Okay. Now, a lot of the time when you see these numbers of like what percent of weight loss, that includes a placebo effect. So placebo is generally 2 to 3%. And so if it says like 7%, that often means it's just 4% more than placebo. Okay. But remember that placebo effect is sometimes these numbers can be confusing. Sometimes they will say like the amount of weight loss more than placebo, and sometimes they will just say the amount of weight loss, which includes placebo. And so, like I said, you could get confused there. You could be like, oh, wow, this one's 15 compared to this one's 18. And they may actually be the same because the one where they were reporting 18, for whatever reason, they were including the placebo, and the other one they weren't. So sometimes I see them reported in different ways. And so that's important to keep in mind. I believe this does include placebo to say 5 to 7%. So it's not a huge weight loss. But as we've talked about in the past, 10% is generally like our goal. Like we want to get at least 10%, right? 5 is considered pretty good though. I mean, in a 200-pound individual, that's 10 pounds. So that's not too shabby. 10% though is what gives us, if you remember back when I was talking on the last episode about medication treatment indications, 10% weight loss is like decreasing your diabetes risk by 80%. Your 10% weight loss improves your AHI if you have sleep apnea. 10% in a fatty liver improves fibrosis. So 10% is like really, really good. But 5's not bad. 5% loss leads to a 50% reduced risk of diabetes. Your A1C and blood pressure and lipids will respond to a 3 to 5% fat loss or weight loss. Sorry. And 5% weight loss reduces the risk of steatosis, so fatty liver. So 5% is kind of our minimum to start seeing health benefits. And we generally max out around 10%, unless this is a very, very large individual. Typically at around 10, maybe 15%. I've got here 15% leads to a 95% reduced risk of diabetes, and 10% is an 80% reduced risk. So in the 10 to 15% range of weight loss, we're maxing out like our metabolic risks. So you, like I talked about before, you may not be happy with the way your body looks yet, but you've improved your health span. And that's what's important. All right. So 5% is generally pretty good, but we're looking for a little bit more. But phentermine, 5 to 7%, that is decent. Some people will, of course, some people will lose more. Some people will lose less. That is the average. All right. And then remember, I mentioned the FDA only has this approved for short-term weight loss. Now, what does that mean? Okay. So that means 3 months, 12 weeks. That means 12 weeks. So some states actually don't even allow long-term use. I'm talking about you, Ohio, and you, Florida. I'm not aware of other states, but like they actually say you can't give this for more than 12 weeks. However, you can like safely give this long term. Now, if your state says you can't do it, then you can't do it. But if you're not in one of these states and it's only FDA approved for 12 weeks, that doesn't mean you can't off label go longer. Okay. So I don't have a problem going longer than 12 weeks. I would want to make sure that it were legal where I was practicing. And even if it is, you can take a 1 month off and start that clock over again. Okay. So, when this med was kind of this, like I said, this is like the first of the first, right? So when this was initially being looked at, um, it was kind of like, oh, we can only use this short term. But if you look at Qsimia, which we'll talk about next time, it contains phentermine and it does not have this time limit. And that's because phentermine is not dangerous to take long term if it's being monitored, right? If we're seeing problems from it, then certainly, but we can't just across the board say, oh, it's only 12 weeks. Like it won't work after that and it won't, and it'll be harmful after that. Though this is not true. Okay. The FDA has not reviewed their 12-week limit on phentermine in decades. So we have, and we have seen studies that show it safely used beyond 12 weeks. So I'm okay with it. Some people only need it short term. It's like they lose the weight. Sometimes they might, be at risk of losing too much or continuing to lose weight, and they need to like go off of a appetite suppressant. And then they would then, be able to go on it later if they start to gain the weight back again. So a lot of people that take phentermine will take it in episodes when they need it, or maybe they have something that triggers them to gain weight and they're like, I need to go on my phentermine. A lot of people don't like taking it, and so like they like, oh, I take it for a short period of time, but I wouldn't want to take it every day. But there's different doses, and so we can also consider lowering doses if the tolerance is an issue. All right. And then another thing, this can be used off label for concentration. So as you remember, our stimulants for ADHD are stimulants. They are NDRIs for the most part. And this is a norepinephrine releasing agent. It works a little bit the way an ADHD med does. And it's also a stimulant. It's kind of nice. I'm talking about a stimulant. We're talking about stimulants. I just talked about non-stimulants in the last ADHD episode, but this is a stimulant. If you've got co-occurring ADHD and obesity, and they often do go together, folks with ADHD may impulsively not control their diet well and can gain weight. And then this could help them lose that weight and treat their ADHD. The other meds for ADHD can also suppress appetite, so those are also options as well. But maybe they don't like them, don't tolerate them. The dosing, we've got a 15 milligram option. We've got a 30. We've got a 37.5. You can split the 37.5. I think we've got 18.5. You can take this between 1 and 3 times a day. The max dose in a day would be 37.5. So some people that taking it in the morning works best for them. Some people will want to take a morning dose to suppress their appetite for breakfast and then a lunch dose to suppress their appetite for lunch. If you take it for dinner to suppress, you might run into some sleep issues, make it difficult to sleep. There is actually an 8 milligram version floating around out there that is kind of engineered to take 30 minutes before each of 3 meals. Its brand name is Lomira. It came out in 2016. You can kind of engineer Lomira with the with the generic phentermine. I mean, give them a 15. I mean, you split that, what, that's 7.5. And you could take that 7.5 3 times a day and basically kind of mimic that Lomira. We can split these pills. I usually start people out with 15 milligrams and then tell them they can go up to 30 on their own if they feel like the 15 was inadequate, or they can take, if they feel like the 15 worked well, but like it wore off and they binged later, that they could either take the two 15s at the same time, or they could split it and take a 15 at 2 times of the different of the day. I like to give patients a lot of flexibility with how they take medications, to because I don't want to have to tell them exactly what to do, and then they come back and then they report, and then I'm like, okay, we'll make this change, and I'll see you back again. Okay, make this change. So I like to describe to them, okay, I'm giving you a range. You can go within this range, and especially with medications like this that work fast. Like with an antidepressant, I'm probably not going to do that because it takes so long to see the effects of changes. But with like stimulant medications, like for ADHD and then phentermine, the the effects quite quickly. And so I'll say, here's some 15s. If you want to split those, I'm cool with it. If you want to double up on it, I'm cool with it. Don't take more than 30 in a day. Um, you take you could take a full 15, and then you could take a half of a 15 later in the afternoon, because you don't feel like you need the full dose again. You do you, right? You do whatever you want with these 15s. I'm allowing you to take up to 2 a day. And if they come back and they're like, you know what, the 30 a day works really well for me, I don't think they make a 30. So then I say, you know what, so you don't have to take 2 15s. Here's a 37.5, and I'll give them the 37.5. If they're taking both the 15s at the same time. So that's how I like to dose it. I find that works, and I like to describe it like, you may need these. You may just like take it once and it covers you for the day, or you may need to time this with your meals, um, and you may need to take different doses at different times depending on different situations. And I'm cool with that, as long as I have, like, don't take more than this in a day. You can kind of take it how you want, that you think works best for you, up to that. And I think giving them that autonomy, it helps with the efficacy as well, and tolerance. All right. So speaking of tolerance, what are we concerned about here? So it is a stimulant. So we're looking at cardiovascular, hemodynamics. We're looking at heart rate. We're looking at blood pressure. As I mentioned, difficulty sleeping, anxiety. Those are some things. This medication, it works a lot like a lot of our psych drugs does, like a lot of our psych drugs do. So this is something that I think psychiatrists should be very comfortable with. This medication works very similarly to a lot of our medications, and so, like, there should be no problem learning how to use phentermine. And the important thing about phentermine is, if you're going to start somebody on medications for weight loss, you, in order to get the approvals for the other meds, pretty much every insurance company is going to require a trial of phentermine. And that's why it's so important to know how to use it. Pretty much with every one of your weight loss patients that you're going to use medications in, you got to give them phentermine first to get to anything else. All right. So always start with phentermine, but not always, because there's some contraindications. So we're going to get into that. So what are some more adverse effects? All right. So, I mentioned the heart rate and blood pressure, and I think I mentioned there's 3 things that people freak out about when they hear phentermine. 1, Schedule 4 drug. 2, heart rate and blood pressure. And 3 is its association with fenfluramine, fenfen. So we'll talk about that when we talk about fenfluramine. But while we're talking about heart rate and blood pressure, bupropion actually is more likely to cause increased heart rate and high blood pressure than phentermine is. And so everyone's comfortable prescribing bupropion. Well, if you're comfortable with that, then get comfortable with phentermine, because it's safer. All right. And then, like, the fear of the dangers are overstated. It's that connection to fenfluramine. Fenfluramine is the dangerous drug in the fenfen. We're going to talk about fenfluramine in a second. So Phentermine has nothing to do with fenfluramine, all right, other than the fact that they were prescribed together, all right. So, but all the risk was fenfluramine, none of the risk was from phentermine, okay. So you're just going to want to monitor vital signs with those changes. Consider stopping if the vital signs are elevated, and you think it's because of the medication. And then there's some contraindications to using phentermine. And so, like, oftentimes when you're trying to get other medications approved, you could skip phentermine, and you would want to skip it if there was a contraindication. So you say, well, I can't use phentermine. We have to go to the next step because this patient has X, Y, and Z, right? So what are the contraindications? Cardiovascular disease. So pretty significant, irregular heart rates, heart failure, coronary artery disease, stroke, uncontrolled hypertension. So anything where like increased heart rate or blood pressure is going to be a massive problem and could kill a person, that's reasons not to use phentermine. All right. But as I said, like if you're comfortable with bupropion in these same patients, then you shouldn't be afraid of phentermine. You should probably be concerned about bupropion in these patients as well. All right. So some other stuff. This all has to do with high blood pressure. So like hyperthyroid, angle closure glaucoma, agitation. So if this is an agitated patient, we don't want to give something that could make them more agitated. If they have a history of drug abuse, you could kind of use that as an excuse if you're looking for an excuse. But like, I honestly don't think that phentermine is, I've never heard of a case of somebody like abusing phentermine like a drug, but a history of drug abuse is labeled as a contraindication. And I think if you think this is the kind of patient that like is not going to, if you're like seasoned with obesity medicine, and you're like, you know what, I really don't want to waste time with phentermine on this patient because I think it's not going to go well, and they have a history of drug abuse. Hey, that's something that you could use to say that it's contraindicated when you're trying to get it approved by the insurance company. All right, so that's where that piece of information will come in handy for you. All right. Remember the serotonin stuff I mentioned before? Use of MAOI within 14 days, no go with phentermine, right? So this has got an MAOI contraindication, but of course that's for all the reasons. MAOIs block the breakdown of all of our serotonin, norepinephrine, dopamine. We can get the hypertensive crisis, right? We don't want, so we have to, and not a lot of patients are on MAOIs, but if they are, don't take phentermine within 14 days on either end, right? Either before you start an MAOI, you have to wait 14 days after stopping phentermine, or after stopping MAOI, you have to wait 14 days to start phentermine. It's on both ends for different reasons. Listen to my episode if you want to know why on MAOIs. And also pregnancy and breastfeeding. And that is a contraindication of pretty much every one of these meds. Every FDA approved med, it is. And I mean, when you've got a pregnant patient, you're really not typically looking for weight loss. Metformin would be the only like somewhat weight controlling medication that would be approved for pregnancy, but I would not give it for that specifically. All right, so that's phentermine. I hope you really enjoyed learning about phentermine. That is a really important drug, and it's one that if you're going to treat obesity medicine, you're going to be using a lot of. And that's all the ins and outs. All right. Let's breeze through a couple of ones that you're probably never going to encounter. And one of those is diethylpropion. Sounds like bupropion, right? Well, it works a little bit like it. Brand name Tenuate. Came out in 1959. Schedule 4 med. It works similarly to phentermine, norepinephrine releasing agent. It's also known as amphetamine. It's a prodrug of ethcathinone. It's FDA approved for short-term weight loss for those 17 and older. So this exists. You can prescribe diethylpropion if you want. It's dosed 25 milligrams 3 times a day, or controlled release 75 milligrams in the morning. Adverse effects: heart rate, blood pressure, insomnia, contraindications, that same cardiovascular stuff, hyperthyroid, MAOI, all that stuff, same as phentermine, and pregnancy breastfeeding. It's very similar to phentermine. I think we don't prescribe this one because phentermine's out there. and that's what everyone uses, and that's what we're familiar with, right? Next one that you've never heard of, phendimetrazine, otherwise known as Anorex, also came out in 1959. Oddly, this one is Schedule 3, so higher level. It is a norepinephrine dopamine releasing agent, so not just norepinephrine, but dopamine. And remember, all these are releasing agents, not reuptake inhibitors. It is a substituted amphetamine, is a prodrug of phenmetrazine. So phendimetrazine is a prodrug of phenmetrazine. Phenmetrazine used to be a medication. It was withdrawn from the market in the 1980s. Not really sure why. Phendimetrazine produces a steadier long-acting blood level, so it's a better med. It's FDA approved for short-term weight loss. Those is 17 and up. Dose 17.5 to 35 milligrams 2 to 3 times a day. There's an extended release 105 milligrams in the morning. Same adverse effects, same contraindications. All right. So another med that has a lot of similarities to phentermine, but it also is a dopamine releasing agent. That sounds like it might even have some good effect. I mean, I would actually, I mean, I don't know another med that is a norepinephrine dopamine releasing agent. I feel like phendimetrazine might be something fun to play with. But like, I just don't know if pharmacies carry this thing, right? And here's the thing on these, like, and there's one more we're going to talk about. But we have to talk about another one first. But there's a third one that is kind of you've never heard of one. But with these insurance things, they will often say must try. This is how I actually found out about these. It said must try phentermine or diethylpropion or phendimetrazine, or the last one is benzphetamine. And I was just like, I've never heard of benzphetamine or diethylpropion or phendimetrazine. And it's like, well, you can, any one of these is typically okay. They will meet the phentermine. You don't have to use phentermine. You can use one of these other three. I don't know why you would, because I don't know where you're going to find it. But they're a little bit different. You know, diethylpropion has a similar mechanism of action. Phendimetrazine is a norepinephrine dopamine releasing agent. So that's kind of, I don't know, that to me, that's interesting. Like, would this be helpful for ADHD? Would this be helpful for depression? Is this like a stronger bupropion? I mean, I would be interested if I could get my hands on this stuff. And I'd love to see some studies. You know, I often mention, like, I wish I could study this if I had the time and the resources and I worked at a research institution. Well, any of you out there that's listening to this that do, hey, can you test phendimetrazine for me for depression and ADHD? Because norepinephrine dopamine releasing agent, that's kind of cool, actually. And let's go ahead and skip over to that fourth one, benzphetamine, brand name Didrex, came out in 1973. This is also Schedule 3. It is actually a norepinephrine dopamine reuptake inhibitor, similar to bupropion, but it's also a dopamine releasing agent. So kind of sounds similar to Adderall, doesn't it? Because it's a NDRI and a DRA. So this would be another one to study in ADHD and depression, I feel like. It is a prodrug of dextroamphetamine and dextromethamphetamine. That's cool. So it basically turns into dextroamphetamine, which is, I mean, Vyvanse turns into dextroamphetamine, right? Lisdexamphetamine. And then I think it was Dexedrine is dextroamphetamine. So essentially this turns into dextroamphetamine, but it also turns into dextromethamphetamine. And if you'll remember, dextromethamphetamine is the active form. Levo is found in like nasal decongestant. So wow, this stuff turns into methamphetamine, and methamphetamine itself is a Schedule 2. So this actually turns into dextroamphetamine and dextromethamphetamine. This would be another interesting one to study, because this is like legal stuff, right? Like, this is, I bet they sneak stuff like this into like supplements illegally. This is like the kind of thing that you would find in some random supplement, some drug you've never heard of, but actually exists and is prescribable, but is a scheduled medication and not supposed to be in there. I was watching a YouTube video, and this guy took this sleep drug. He tested it, and it's like there was freaking Phenibut in there, and I was like, that's like not legal to sell in the US and Canada. Probably shouldn't be having a video about you using it. But anyway, you'd be surprised what crap they put into supplements and somehow get away with selling. So benzphetamine, it's also FDA approved for short-term weight loss, 17 and up, dose 25 to 50 in the morning, max 53 times a day. Same adverse effects, same contraindications. All right, so benzphetamine and phendimetrazine and diethylpropion and phentermine are all pretty similar. They have very similar dosings, similar contraindications, similar adverse effects, slightly different mechanisms of action. Phentermine is a norepinephrine releasing agent and activates pro-opiomelanocortin. Diethylpropion is a norepinephrine releasing agent. I don't know if it has effects on POMC. Phendimetrazine is a norepinephrine dopamine releasing agent. I don't know how much it does of each. It may be negligible on one or the other. And benzphetamine is a NDRI and dopamine releasing agent. So a little bit difference there, but those are all options as your first step. But you're probably just going to use phentermine. Now, if you want to be super cool and get have a weight loss clinic and get super into this, I bet you could find a use of these other three if you could find a pharmacy that carries them. All right. So next, we're going to talk about amphetamines we've heard of. All right. Things like Adderall. Right. So amphetamine salts. So interestingly, the first approved use of good old amphetamine salts was a drug called Obetrol. Sounds like obesity because it was used for obesity. Came out in 1960. It's a Schedule 2. So I think that's the other interesting thing about some of these other meds we talked about. Like, so benzphetamine, even though it turns into dextroamphetamine and dextromethamphetamine, it's Schedule 3, which makes it slightly more appetizing to prescribe. So, like, I would really like to study that for ADHD. And then the phendimetrazine, also being Schedule 3, is a lower level than the amphetamine salts at Schedule 2. And then the diethylpropion is very similar to phentermine, so it's Schedule 4. But good old Schedule 2 for the amphetamine salts, Obetrol 1960. As we know, this is a norepinephrine dopamine reuptake inhibitor and dopamine releasing agent. Obetrol, let's learn a little bit about the history. Obetrol was withdrawn in 1973. So 1960 and 1973, withdrawn by the FDA due to concerns for abuse. So see you later, Obetrol. You're out of here. Obetrol actually also contains a little bit of methamphetamines. And that was really the reason why it was withdrawn. It was because the methamphetamine was in there. And so it's not Obetrol if it doesn't have meth. All right. So Obetrol's gone, 1973. Methamphetamine is removed from the product. So it turns into just mixed amphetamine salts now, which is its current form. And it was rebranded as Adderall, which was available, but not FDA approved until 1996 for ADHD. So essentially, they took the methamphetamine out of Obetrol because it was withdrawn from the market due to concerns of abuse. Makes sense. Although, of course, we know methamphetamine is still available as a Schedule 2 prescribable substance. I've never, I heard of somebody actually taking this crazy influencer Clavicular. Look him up. Uses he's like this trying to look perfect crazy kid, and he uses he brags about using methamphetamine, but then he's like, oh, it's actually the prescribable methamphetamine for ADHD at low dose. And so yeah, methamphetamine, I guess he gets it. He's the only person I've ever heard of that actually took the prescribable, available methamphetamine product. So this stuff is out there. It's just not in my pharmacy. So yeah, the meth was removed. It was rebranded as Adderall, but it was available to prescribe, but it was not approved for ADHD until 1996. I don't know if it was approved for weight loss before that or what. I don't know, because Adderall ADD, that is obviously named after ADHD used to be called ADD. So there are currently some but of course Adderall is not FDA approved for weight loss, right? So there are some amphetamine salts, and I believe we've talked about these on our ADHD series, that actually are approved for obesity. So let's talk about these. Lisdexamphetamine Vyvanse, 30 to 70 milligrams in the morning. Prodrug of the right enantiomer of amphetamine. We've talked about this medication on our other series. If you want to learn more about Vyvanse, tune in there. It's FDA approved for, of course, ADHD, but it is FDA approved for binge eating disorder, adults only, so 18 and up. Um, it's very explicit on my prescribing guidelines for my pharmacy to approve this, is that I cannot use Vyvanse for weight loss, but I can use it for binge eating disorder. Just go ahead and take a look at the criteria for binge eating disorder. It's extremely vague. Um, if you really wanted to think, oh, this person has binge eating disorder, it's not hard. It's honestly, a lot of people, like almost everyone, could almost be diagnosed with binge eating disorder if they eat more. It's like eat more than you think you should, this number of times a week or something. And it's like a lot of people do that and they don't actually have a binge eating disorder, but like you could fudge it. If you're trying to get Vyvanse approved by the insurance company, it's not hard to like come up with a diagnosis of binge eating disorder for a patient. And honestly, people that are obese, very, very few people that are obese do not meet the criteria for binge eating disorder. Very few. It's just like eats more than they think they should this number of times a week. I mean, what obese person is not going to say, yes, I do that, and what I mean, and doesn't do that? So if you're inclined to use some Vyvanse for weight, give them the give them the diagnosis of binge eating disorder, and you can do that because it is FDA approved for that, so the insurance will pay for it. And where this comes in handy is actually, a lot of the GLP-1s can be hard to prescribe, hard to get insurance to pay for them. It's not hard to get this paid for. This is generic now. It's not that expensive. It's just a lot easier to get it approved. And I've found that a lot of people that start on a GLP-1 but like don't like it, don't tolerate it, but like they lose a lot of weight on it, but like long term, it's just not something they want to do forever. But if they stop it, they gain the weight back. Oftentimes, putting them on Vyvanse after you pull them off the GLP-1 can do the job. So that is a big place I see Vyvanse. And I don't hear people talking about this. This is like personal experience. This is just like what I've kind of noticed with patients is that, and I also noticed that a lot of obese patients have ADHD, and so it's often not hard to make a ADHD diagnosis in a patient that has obesity because there's a lot of comorbidity there, and it's not hard to make a binge eating disorder diagnosis in an obese patient because most of them qualify. I mean, I don't know if that's their primary issue, but like they certainly like meet the criteria for it, so they can justify using a med that you want to give them, right? I'm not going to justify things I don't want to do. But if I think something's going to benefit a patient, and then I can find a way of fitting that with FDA approvals and insurance, then all the better, right? Otherwise, I want to give it to them and I prescribe it, but then we can't get it paid for. Um, and then they can't take it. So let's use the rules to our favor, right? I'm not saying to do stuff you're not supposed to do. I'm saying use these easy rules to your favor. And yeah, I think Vyvanse is often a great option for like post GLP-1, and I think that's something that I would. Another thing, I want to see that studied. There's no studies on that. This is anecdotal, but the thing is, a lot of people are throwing, like, especially out there on the podcast world and the YouTube world, they're throwing a lot of anecdotal crap out into ether that is just based on but they're trying to like make a lot of money off this stuff. They're trying to be really like controversial and get a lot of viewers by being controversial, and they make a lot of money. And they may be even like making this stuff up, and a lot of this stuff is just placebo based, and I don't trust any of that. And so you're thinking, well, then why the hell should I trust you? Aren't you doing the same thing, punk rock psychiatrist, with your like out of the box thinking? Well, I'm not trying to like get money here. I'm not like getting sponsors. I'm telling you, and also a lot of the stuff that these like influencers are telling you, we have scientific evidence to prove that they're wrong. Or, we have studies that show that what they're saying doesn't work. And so, but then they're saying it anyway. Now, using Vyvanse after GLP-1 is something that hasn't been studied. And so we can't say, I mean, if there's been a huge trial that like was a really well designed trial and it showed like this is a bad idea, then I would not be suggesting it as a possibility. I'd be like, okay, I've seen this work and stuff, but like, hey, we've got this study that suggests that it's not a great idea. So we definitely need to consider that. But we don't have any studies. Sometimes there are no studies to say yes or no. And you've got a patient that's not responding to anything else. And this is what happens. These patients have tried everything. And they're like, nothing's working. And then they go to some quack and they come up with some crazy thing, often things that like don't work. And then they give them all their money. And that's not cool. This is at least based in some sort of reality, right? We have Vyvanse with an FDA approval for an eating problem. It's also approved for ADHD. This patient may have ADHD. They may have binge eating disorder. I think it makes very much logical sense. If the GLP-1, maybe they're not getting it paid for anymore. Maybe they're not tolerated anymore. Maybe it's causing them to lose too much weight. Maybe they don't like sticking themselves. A lot of different reasons. But maybe they need it to maintain the weight loss. Vyvanse is a good option. Okay? So, hey, this is a really good one. So that's the first FDA approved amphetamine salt for weight loss. The other two are not ones you're really going to use, but I will throw them out there anyway. One of them is amphetamine sulfate base Evakeo. We've talked about Evakeo and ADHD, 5 to 30 milligrams in the morning. You can split. It is approved for exogenous obesity for children greater than or equal to 12. Exogenous obesity just means that they are obese. They have subcutaneous fat and they're obese. So you can totally use this. It's not really any different than Adderall, but it has an FDA approval. And when it says children greater than or equal to 12, I don't think adults use Evakeo. I also think the doses might be too weak. But in kids, Evakeo is totally an option. I've never even seen Evakeo out in the wild, but it is out there. All right. So, and I talk about Evakeo in the ADHD episode about it. And the last one is dextroamphetamine, Procentra or Zenzetti. Remember, I mentioned dextroamphetamine is Dexedrine, but Dexedrine doesn't really exist anymore. And so Zenzetti kind of was like branded to replace it, and now it's off patent too. So now we can get like just generic dextroamphetamine. Procentra is the liquid version. These are both drugs that we use for ADHD. 5 milligrams in the morning, max 10 twice a day. But they also have an FDA approval for obesity secondary to hypothalamic pituitary dysfunction in children greater than or equal to 2 years old. I'm not real sure how to diagnose obesity secondary to hypothalamic pituitary dysfunction. I would probably leave that up to our pediatric endocrinologist friends. And so I will not be prescribing Procentra and Zenzetti in children 2 and up for obesity. Evakeo for 12 and up, I mean, I wouldn't be opposed to that. Vyvanse, as you know, I love, but that's only, it's approved for kids for ADHD, but only approved for adults for obesity. So you can't give Vyvanse to kids for obesity, but you can for ADHD. Like I said, we're going to go over, once we talk about all the meds, which meds we can give to kids and which ones we can't, and what ages. I mean, as we see here, this one's 2 and up, 12 and up, adult and up. But then they have other indications that could be used at different ages. All important to know. All right. Let's go through a couple more of these and then we'll get up to Qsymia, and we'll talk about Qsymia next time. So fenfluramine, I think it's really important to talk about that in this episode because of its connection to phentermine, as I mentioned before, the fen-phen combination. If you are probably older than me, but my age, and you watched daytime television in the 1990s, you may remember fenfluramine. Brand name Phentermine. It was approved in 1973 and it was withdrawn in 1997. Phentermine no longer exists. It is a serotonin releasing agent. Oh, hey, look, here's another serotonin releasing agent. Remember we talked about ecstasy before. So, oh, it works a little bit like ecstasy. Probably not good for you. So fenfluramine was actually, so it was taken off the market in 1997. We'll find out why in a second. It was repurposed. So Phentermine gone, but it was repurposed as Fenlepta, brand name Fenlepta. So you can still get fenfluramine. 2020, it was rebranded as Fenlepta. However, it is only approved for two different seizure disorders. I'm not even really sure how to pronounce these. I'm not a neurologist. One of them is Dravet syndrome. I don't know if that's Dravet or Dravet. If it, sometimes we pronounce things the wrong way when they came from French, and sometimes we pronounce it the right way. So I don't know if it's supposed to be pronounced Dravet or Dravet. And then we've got Lennox-Gastaut. I'm going to say Gastaut, but maybe it's Gastaut. Maybe we're pronouncing this French name incorrectly as well. So Lennox-Gastaut syndrome, it's another seizure disorder. So Fenlepta, I'd be darn careful with it. Obviously, we're not prescribing this unless we're like pediatric neurologists. So that's the only way that fenfluramine is actually available anymore. Let's talk about the fenfluramine-phentermine combination pill. It didn't exist. There was no combination. They were separately prescribed. This was never approved. This was never a thing. This was just like, so we had a serotonin releasing agent and a norepinephrine releasing agent. It was kind of dubbed fen-phen, right? That's what it was popularly known. It was on like magazines. This was huge. Oprah was on in the 90s, right? This is probably like on Oprah. It was on Sally Jesse. It was on probably like Jerry Springer. Like, for those of you that remember the good old talk, these daytime talk shows, back in the 90s, fen-phen was on there, and then like the bad outcomes from fen-phen were on there. Like I watched this stuff sometimes because I don't know, I had nothing better to do with my time. So the combo was never FDA approved, but it was just like somebody kind of figured this out and was like, hey, this is a weight suppressant. This is a weight suppression. If I put them together, people lose a crap ton of weight. And it really worked. It was very popular, very effective weight loss treatment. There was some article published somewhere in 1992 where someone talked about combining these pills. So the Phentermine, which was it was approved. It was approved for obesity. So that's the thing. I didn't mention that before. The Phentermine that was like 1973 to 1997, that was actually an obesity medication, but then the phentermine was added on top of it. Okay, so to give even more weight loss, right? So this is how phentermine got a bad name. It got combined with fenfluramine, and fenfluramine was floating out there for 25 years for obesity, and this obesity indication was withdrawn in 1997, repurposed in 2020 for seizure disorders. And the reason why was because of cardiotoxicity. So it caused valvular disease and pulmonary hypertension. So it was, it basically like messed up your heart and it killed people, right? Like it caused like heart attacks and stuff. Pulmonary hypertension, that's bad, right? Valvular disease, you don't want your valves of your heart. The things that are like allowing blood to flow in and out of your heart in an orderly manner, you don't want that getting diseased. That's bad. So I guess it took us 25 years to figure this out, and then they pulled it off the market. For just a little bit there was a dexfenfluramine floating around. I don't know what the brand name was. I couldn't find the brand name of dexphenfluramine. It was approved for weight loss from 1996 to 1997, and it got pulled the same time that Phentermine was pulled. But like this was like a huge thing. It was huge. It was just like this was such a popular weight loss technique, and unfortunately, Phentermine's good name was sullied by its association to fenfluramine in the fen product, and they were like, I don't want to have any fen in me at all, because fenfluramine is F-E-N and phentermine is P-H-E-N. So fen was F-E-N hyphen P-H-E-N. It was like fenfluramine from phentermine. And so poor phentermine got confused with fenfluramine, and like people just like didn't want to prescribe it as much anymore. But that's not an issue. All right, let's talk about a couple more. Sibutrimine, brand name Meridia. This is another bit the dust medication. It was out there in 1997 until 2010. It was in serotonin norepinephrine reuptake inhibitor, so SNRI, withdrawn from the market by the FDA in 2010 due to association with increased heart attacks and strokes in patients with a history of cardiovascular disease. The risk was 11.4% versus 10% in control, so not nothing. I mention this because, one, historically it was out there and kind of its mechanism of action, but also this is something that has been found in supplements marketed as natural and traditional and herbal remedies, right? And so like, you threw some sibutramine in there, you threw something that was like taken off the market by the FDA because it causes cardiovascular disease. It's floating out there. So it's something that you want to be aware exists, because someone might be telling you like, hey, I'm taking this natural traditional supplement for weight loss and it's really working, and you're like, can you bring that in and tell me, and can I look up what's in there? And you're like, sibutramine, that was taken off the market. But like I said, that YouTube video I saw, the guy had phenibut, which is like was never approved, and actually like is illegal to market it for anything, and there it is in there. I've heard of meth being found in supplements. People are buying this stuff over the counter. There's meth in it. It's nuts. And that's it. We're gonna wrap up with sibutramine. And next time we're gonna talk about Qsymia and Contrave, and it's probably gonna be a shorter episode because I'm just gonna talk about those two meds, but they're two big ones you need to know about. And then after that, we've got a ton of stuff about GLP-1s. So I hope you enjoyed our trip through history on all these like weight loss meds that like no longer exist anymore, but also Phentermine, that's like super important, and then Vyvanse, which is like really, I think more people need to like realize how important that could be for weight loss. And then those other three meds that like you've never heard of, but like still exist and have cool mechanisms of action that somebody needs to study for like other mental health conditions, but like no one's doing it. It's like, stop studying all this stuff that's boring and like no one cares about. Like, we got drugs out there that exist, that have mechanisms of action that none of our drugs we're commonly using have, that look like they could have some sort of positive impact. Let's look into these things, right? So I want to thank you so much for tuning in today. I hope you enjoyed the episode. I hope to see you next time.